Good evening, ladies and gentlemen. Thank you very much for your invitation. My name is Marta Skowronska. I'm a neurologist and I work in Warsaw, Poland, and I work mainly with MPAN patients. And I would like to present two studies that are ongoing in our department, two clinical studies about MPAN research. Here are my financial disclosures. I have received a financial grant from NBIA. And the first study I would like to present was partly published in 2020. And we thought that MPAN patients who suffer from optic nerve atrophy and dementia are somehow similar to other group of diseases called mitochondrial diseases. C19 or 12 is a gene that encodes protein somehow connected to mitochondria. So we thought that maybe MPAN patients might suffer from heart disease like patients with mitochondrial diseases. About 30% of patients with mitochondrial diseases have heart disease. 10% of them experience minor adverse cardiovascular events. And the most common abnormalities which are seen in mitochondrial disease patients are cardiomyopathy and cardiac arrhythmias. So we have performed a study, which was, this table was published in the paper I showed previously. With this table was slightly modified, and I will show you the modifications. First of all, we have examined 13 patients, 3 of them were females. As you can see, most of them were carrying our typical Polish mutation, which is the deletion. But we also had some patients with other mutations. They were all adult patients with age ranging from 18 to 27. All of them, except one, suffered from optic nerve atrophy. All of them, once again, except one, suffered from neuropathy, which are typical for MPAN. And all of them, right, had some kind of cognitive impairment or even dementia. What we have found in cardiac examination, first in echocardiography, that left ventricle ejection fraction was normal in all cases, starting from the younger ones and ending at the oldest patient, who was 27. But in 24 hours Holter ECG, we found some abnormalities with predominant tachycardia. And in 2 cases, we found some cardiac arrhythmias. In one case, it was sinus burst, nearly 3 seconds, lasting nearly 3 seconds. And in one case, this is the modification, because atrial fibrillation, paroxysmal atrial fibrillation, was found during this year examination. So in the paper, there was just predominant tachycardia in this case as well. If we would like to summarize our results, cardiomyopathy, which was typical for mitochondrial diseases and seen even if in echocardiography, was not found in our MPAN patients. All of them had left ventricle ejection fraction over 60%. Of course, we didn't perform more specific studies for cardiomyopathy, like magnetic resonance of the heart, but in cases of mitochondrial diseases, cardiomyopathy is seen even if in echocardiography. What we have found was that heart rate heart rate variability was lower than average, and heart rate variability depends on the interplay between parasympathetic and sympathetic nervous system. So we thought that maybe MPAN patients suffer from dysautonomia. And this year we have performed a study on larger group because we have 26 MPAN patients. And we have examined all younger patients because age range was from 12 to 29. All of them had 24-hour ECG, but also we performed some more specific electrophysiological studies, like changes in heart rate during deep breathing and Valsalva maneuver, together with sympathetic skin response. And what we found was pathological results in electrophysiological study in all our cases, which confirmed dysautonomia in MPAN patients. So, in conclusions, we are preparing a paper about this study. Is about the conclusion. First conclusion is that MPAN patients suffer also from sympathetic and parasympathetic impairment. And this conclusion was also made in the paper that we recommend the standard cardiac workup in all MPAN patients because some cardiac arrhythmia might be found, and we found in two our cases cardiac arrhythmias. First, atrial fibrillation. Second, the sinus pulse, and both those patients are treated with additional treatment. The second study is ongoing, so I will share only a few our observations with you because we have no conclusions yet. We had an observation, clinical observation, that MPAN patients are somehow sensitive to starvation and intense physical activity. We didn't measure the intensity of physical activity and the duration of starvation. It was just a clinical observation. And both those states, I mean starvation and intense physical activity, causes neurological deterioration, which seems to be reversible after a meal or a rest. But we don't know whether it's fully reversible. It seems to be reversible, but maybe not. So we have designed a study where patients are treated with regular meals, inadequate caloric supply, and some other diet supplies. And we are hoping that this might prevent further deterioration of MPAN patients. We have only 3 months of observation because the study is ongoing, and we started in February, so we are now having the first time point and time and first observations. And I'm afraid they are not conclusive yet. The second time point it will be after 6 months of this treatment. So I hope that during next conference I might present some more details about this study. I'm afraid that is all I have prepared for today. We do not have many clinical studies going on right now because of COVID, which stops us. My department is really coping with this. So thank you very much for your attention, and I think that the questions will be asked after all presentations. Thank you once again.